up live, and this is truly live. I hit Tyler up this morning. I said, Tyler, help me out. I want to do something about sports today. It's a beautiful day outside. People are getting more active. Kids are in high school playing football, college football. This is Tyler Marshall. Tyler, thanks for coming on.
Sure, happy to be here.
Tyler's done this with me before. He's a sports medicine surgeon. And we're going to talk a little bit about ACL injuries to start with. And if people put in questions, maybe you can just let us know, Brett, okay? So you pulled up a case for us, I see.
Yeah, so
you can either get it up there or up there. Let's take out the name. Let's right there. Let's block out the name. Perfect. Okay, what you got?
So, bring up the topic of sports medicine and football season and what's a very common injury that everybody hears about.
I'm going to move over here, Brett. So
one is anterior cruciate ligament injury, ACL tears. You hear about, unfortunately our favorite football player is oftentimes injured early in the year, and then your team is downtrodden and upset because their star athletes out of the game.
So the ACL, I'm going to back up, is in the knee. It's that crisscross ligament that sort of connects the femur bone to the lower leg bone.
Correct.
And helps with stability, I
imagine. It does,
imagine.
And particularly in football players or really any kind of athlete that's changing direction, the ligament can be injured by non-contact twisting injuries. So,
a lot of women get it that play soccer, as I recall, right?
Yeah, women, soccer players is a very high-risk group. And then football players, I think, will be number 2 as far as incident rates go.
Okay, so let's take a look at
so up here, just to start,
you want to go up here?
This is a sagittal MRI, meaning we're taking slices of the knee starting from the outside, moving in or across the body. So here you can see the femur. Here's the tibia. Here's the meniscus. Looks like a bow tie, and that's what it should look like. And then here's the fibular head.
That's the bone in the lower leg on the outside.
Right, so we're starting lateral. And then
starting on the outside, moving our way inside the knee.
We're going to work our way towards the midline, and then you can start to see here, this is the intercondylar notch, and that's where the ACL is. The ACL runs from the femur here down to the tibia, and again, it stabilizes the tibia in relation to the femur as far as anterior translation. So that's an anterior cruciate ligament. It's in front of or anterior to the posterior cruciate, which is this ligament here that runs from the femur posteriorly to the tibia. And
the posterior cruciate ligament looks a little floppy relative to the ACL.
Yeah, it has more of a J-type shape to it. You're right, exactly right. It's a bigger ligament, and that's why it appears darker in intensity on MRI. So that's an intact ACL, and that's how it should appear. Okay.
All right.
And you can see also this knee has very little joint fluid, just a little bit of joint fluid in here, and that's normal. It's physiologic joint fluid.
So now you're going to show us a torn ACL?
Right. So then if you'll scroll down here to this image here, we'll just for consistency's sake, we'll start here laterally. And what we notice immediately is that on the femur and the tibia, you can see these bone bruises, okay? So when you tear your ACL, what happens is the knee does a pivot shift, meaning that the tibia spins abnormally in relation to the femur, and the two kind of collide or knock into each other, and then that causes that bone edema, that bone bruise pattern. And it's very typical. If you ever see this on an MRI scan, I can tell you there's an ACL tear without even looking at the ligament, okay? So that's the first thing we notice. Then as we work our way in towards the intercondylar notch, you can see the ACL has been torn, and there's no ligament present. You can kind of see the stump there on the tibia, and then back up here on the femur, there's a little remnant of the ACL, so it's kind of transected right in the middle. There's the PCL. You can see that looks like it's remained intact and healthy. And then look at this large amount of fluid in the knee joint. That's all blood that's filled up the knee joint capsule, secondary to the ligament rupture.
What was the history with this one?
So this was,
it was some traumatic type of...
Yeah, so this was a young man, he early 20s, playing actually flag football with his school. So he came on in after a twisting injury playing flag football and had an ACL tear.
So have you repaired this already?
Yes, yeah, we did. We repaired this one a couple of months back. this will be an X-ray image showing what that looks like after surgery. So for this gentleman, we did a quadriceps tendon autograft, meaning that we harvest the central slip of the quadriceps, take a bone plug out of the patella and then a slip of the tendon there, and then we use that to rebuild the ACL. You can see we fixate it here on the tibia. There's a little bone plug there. We'll put a screw there, and then the soft tissue graft goes up and traverses the knee here, and then that's fixed by a cortical button on the outside of the femur, and that's how we do the quadriceps tendon ACL reconstruction.
And how long does it take to recover fully from this type of surgery?
Yeah, so
injury.
Right, so it's variable depending on the patient. I think there's a bell curve like everything else, but I'd say anywhere from 6 months to 2 years, depending on that individual patient. Majority of people are going to be right around a year probably before they're back to full speed.
So it's going to be a year before this guy's playing flag football again.
Yes.
That's a bummer.
Yeah.
So do you get patients like me that just don't want surgery because of the time off, and they want to brace it or things like that? And how do you deal with people like me in that regard?
I think that's reasonable for some patients that are maybe lower demand, not going to want to return to play sports. If you don't have an ACL and you try to play football or tennis in your case,
it's just not going to work. Sounds like
soccer. Yeah, I mean the knee is going to be unstable. They're not going to trust it. It's going to give way, and it's going to lead to more and more problems. Lead to other injuries, meniscus tears, earlier onset of arthritis, and that type of thing. So
right.
The ACL reconstruction allows them to get back to their quality of life and preserve their knee down the road.
Which makes a lot of sense. That the burden for me would be the year off from the sport.
Sure.
And finding ways of staying active without that particular sport. That would be challenging. Is there any way to prevent ACL injuries?
Yeah, there is. So we're doing research now, currently working with different therapists and looking at neuromuscular education. So there are different prehab programs that we're implementing in different team scenarios prior to practice, prior to games, warm-up programs that have been shown to decrease the incidence of ACL tears.
So if the ACL tear is due to, let's say, jumping or kicking a soccer ball, perhaps you could rehabilitate that. But if it's due to trauma, if somebody's tackling you and you've got a planted foot, there's not a whole lot you can do to really prevent that, right?
That's correct. There's going to be some that are going to not be preventable, but I think the ones that we can prevent are those where people are kind of landing. We're trying to re-educate people how to land safely, keeping your knees more square instead of having them kind of buckle in when you land. And a lot more important in maybe the female athlete, we've seen a lot of difference in neuromuscular education programs geared towards that particular subset.
So it's not so much the jumping, it's the landing.
Exactly right.
Okay, and again, go over what's wrong with the landing and what's right with the landing, if you know that. It might be a little complicated.
We'd have to get up and kind of act it out, I guess. But so when you land into tear your ACL, most of the time it's what we call a valgus moment across the knee. So you land and your body weight kind of gets away from you. Your center of gravity rotates around your knee. You have your foot's fixed in one spot, and then your body rotates out away from your knee center. Center rotation comes in, and your body weight's away from it. So you have kind of this valgus moment, fixed foot.
With a fixed foot.
And then you spin, and that's what tears the ligament.
I see.
So the neuromuscular education programs are trying to teach people to keep their knees more square. Mm-hmm. So when you land, your body weight's centered over your knee instead of if you're out here like this.
Is there some sort of genetic predisposition to these injuries? And why are women more susceptible than men in certain instances? And any thoughts on that?
I think part of it, women are built differently from their collagen is made to be loose, and that's just the way they're designed for different reasons. There probably is a genetic predisposition, like everything else in medicine. I think that you're more likely to have the diseases or problems that your parents had. Mm-hmm. And then the other thing, biomechanically, that women have a disadvantage, they have wider hips, right? So women have wider hips and more valgus knees, so wider hips, more knock-kneed. most men are more bow-legged. So the bow-legged stature, I think, is protective, whereas the knock-kneed stature is more at risk for having an ACL tear, especially when you have those wider hips. Because again, it's about where's your weight. If you're out here, you're more likely to tear than if you're kind of over the knees like that.
Got it.
So.
Any questions coming in, Brett? Are we okay on that?
I have one. So can a tear heal on its own without surgery? That's from Christy.
No, they can. That's a great question. But the ligament does not heal on its own without surgery.
What about bracing? If they have a tear, what can bracing accomplish? How much stability can be accomplished with bracing? And then a follow-up question is I'm not a big fan of the kinesio tape. It doesn't
Sure.
make a lot of sense to me.
Sure.
I'm curious about what you think about taping I'm curious what you think about dynamic taping, I should say, as opposed to more stabilizing taping, if you know what I'm getting at.
Sure.
Start with the bracing, though, for ACL.
So ACL bracing is widely used across all sports. We really don't have any evidence to show that it's protective at all. It certainly doesn't prevent injury, and then in the rehab process after surgery, a lot of athletes use ACL braces. I'll give them to guys that I have coming back. Again, biomechanically, they cannot prevent a re-tear. There's no data to show that it's preventative. But I think psychologically it does help some athletes return to sport. So for that reason, I'm fine with it. I'm fine if you want to use a brace because you think it is helping give you maybe a little bit of a mental crutch. And I think that's more the role for the ACL brace, but we can't say that they do much. Contrast that with MCL, medial collateral ligament. Football linemen, we do know that those are protective to protect the MCL.
So the MCL, in fact, I've had an injury to my MCL before playing hockey.
Yes.
But the MCL is this ligament on the inside, the medial collateral ligament. It's on the inside of the knee.
Correct.
And so that's generally not treated surgically, am I correct?
That's right. Yeah, it's a very rare instance that you have to have an MCL reconstruction.
And why is that? Is it heals better than the ACL?
It does. Yeah, routinely it heals more reliably. And then the other thing is that we don't do a really good job of reconstructing them. So even with surgery, sometimes that surgical reconstruction stretches out to the same amount of lax that you'd have treated non-operatively.
So I had, I would say, a grade 1 MCL sprain. This is years ago.
Sure.
And I have minimal tenderness on my MCL. But sometimes I'll wake up in the night with it's really painful to straighten out my knee. And I have tenderness right over the origin of my MCL. I don't know if that's a classic symptom or not, but that's my only symptom. And it's not bad enough to do anything about,
Sure.
but I'm just curious about why it affects me in the middle of the night like that. And my knee is I don't want to move. I'm like very protective of it. But once I move it a little bit, it's like I'm fine.
Right. Yeah, it's hard to say. I don't know. I think most things hurt us at night when we have nothing else going on.
All right.
Another question from Jonathan. Thoughts on PRP for ACL tears?
Great question. That's PRP is good for a lot of things, but it's not going to reconstruct the structure of the ligament. We are looking at putting collagen scaffolding in instead of doing a whole reconstruction, putting a collagen scaffold, okay, and then trying to regrow the ligament along that scaffolding, okay, with PRP additive.
So that's still surgical?
That is a surgical procedure, and that's called the Bear procedure. There's actually a lot of research going on nationwide looking at that.
So it sounds like if you had a partial tear,
yes,
doing that might allow things to heal because you've got an intact structure.
Right, and
to an extent.
And in some patients, some younger patients too, we'll see some of these partial tears where the ligaments peeled off the femoral attachment. And we've actually looked at just repairing those instead of taking the whole ligament out and doing a reconstruction with a graft. I've actually been starting to repair some of those and taking the ligament, putting sutures through it, and then reattaching it to the femoral footprint. So that's something that's been kind of evolving over the past couple of years.
And what is the healing time of those type of procedures?
Well, my experience is there's a lot less morbidity associated with that, pain. They don't experience the quadriceps atrophy, so they tend to return to sports sooner. Okay, I think the ligament itself that heals about 3 or 4 months, and I'd probably be comfortable letting somebody get back to sport around 6 months. So yes, it's a faster recovery process.
That would be cool. Anything else?
No questions from there.
Perfect. Okay. Tyler, thanks a lot. I'm sure we'll get some questions that pop in.
Sure.
And I'll try to get you to type in some answers if necessary, all right?
All right, perfect.
Appreciate
Yeah.
it. Thanks so much.
Yeah.
Appreciate
Thanks
it.
for having me.
Thanks, Brett. Thanks for doing that.
Okay.